Hi, my name's Dr. Tony Blau. I have a form of blood cancer called multiple myeloma, and I'm going to just spend a couple of minutes to show you how I've decided to approach my own cancer treatment after a many-year career as a cancer and blood researcher. I have this nerdy graph that depicts my treatment decisions and the outcomes of those decisions. It's been made through my startup company called All for Cure. I and about 500 other multiple myeloma patients participate in All for Cure, along with over 150 clinicians and researchers. So patients enroll, they allow us to access all of their medical records, and from the medical records we pull out information to create a story that's depicted graphically for each of our patients. And this is my story highlighting some of the decisions that I've made. When I come to my All for Cure dashboard, I see my name. If you were to go onto All for Cure and register, you wouldn't see my name here. You would see my unique identifying number. But on this graph, you can see all of my treatment decisions here, all of the treatments that I've received since my diagnosis in April 2015 until now. And then beneath this are labs, graphs that depict how well those treatments have worked in combating my myeloma. And so just to go through things very briefly, I want to highlight the fundamental strategy of my myeloma treatment, and that is to squish it and keep it squished. And so my approach to that has been to begin with relatively conventional treatment, dexamethasone, lenalidomide, and bortezomib. This is a bone-building drug. But after I got this initial treatment, which was remarkably pretty easy for me to tolerate, my tumor markers, these are labs that correspond to how much myeloma I have in my body. These tumor markers fell. And then I went ahead to get a stem cell transplant. And that's a common thing where you take out my cells, give me a big dose of chemotherapy, a big slug of a kind of a rough chemotherapy drug called melphalan, and then you give me back my stem cells so that I can go ahead and make blood. If you didn't do that, you'd wipe out my bone marrow. I wouldn't be able to survive. So this is a relatively common procedure. It's a way to give a big dose of melphalan, and the hope is that it will really further knock down the number of myeloma cells. And what you can see here is from bone marrow results that I've had, the number of myeloma cells that were detected initially per million cells in my bone marrow. This was 80,000. I don't think these units are quite the way that this is used anymore. But after I started treatment, then that number fell. The number of tumor cells in my bone marrow fell, and fell to much, much lower levels. So over 1,000-fold lower levels of tumor cells in my bone marrow following this initial round of treatment than I had at the time that I was diagnosed, roughly. And you would think that perhaps that would be enough. 1,000-fold reduction in my tumor burden is a great result, but I was concerned because that still probably means that at this particular time in my therapy, I estimated that I probably still had at least 10 million myeloma cells in my body at this time. And so 10 million cells is a lot, and the way I think about this is any one of those 10 million cells could resist treatment and come back to cause me problems someday. And so I wanted to hit my myeloma again with another hard punch, and I decided to do a second type of stem cell transplant. And this was from my brother, who is a complete match with me. And we did what was called an allogeneic stem cell transplant, something that's not done very commonly in patients with multiple myeloma. And so these lines depict my allogeneic stem cell transplant. And again, this looked like it further reduced the number of myeloma cells in my bone marrow. And then while I was recovering from my my second stem cell transplant, I was not on myeloma drugs, and during that short period of time, it looked like my myeloma was starting to come back. Kind of a unwelcome result, as the number of cells in my bone marrow seemed to be going up, and it was corresponding with a rise in this protein that is significantly produced by, not solely produced by my myeloma cells, but most of this protein called kappa-free light chains comes from my myeloma. And so I had a bit of a resurgence of my myeloma until I resumed this anti-myeloma treatment, Revlimid, lenalidomide. It's a pill you take every day. And I increased the dose from 5 to 10 to 15 to 20. And over time, the kappa-free light chains fell. And over time, the number of myeloma cells that were detected in my bone marrow fell to undetectable levels. So that was the goal, to get to that point where no myeloma could be found. That does not mean that I don't have myeloma. Not finding myeloma is very different from not having any myeloma left. And it's easily possible that a person who achieves this state, it's also called an MRD negative state, minimum residual disease negative state. It's the thing that I've aspired to, many myeloma patients aspire to, doesn't mean that you're cured. And so I've really been very aggressive about continuing to be treated with the idea that there are very likely to still be myeloma cells there at some low level, and they need to continue to be suppressed. So again, squish it, which is what I did here, and keep it squished, which is what I've done ever since that initial period of therapy with a couple of stem cell transplants. And so the way that I've done the keep it squished part of it is to continue maintenance therapy with a drug called Revlimid. And then at this point, the kappa-free light chains were at the upper limit of normal, making me think that they were that there was still, probably some kappa-free light chains being produced by the myeloma cells, that I couldn't detect them directly, but they were probably making the kappa-free light chain levels a little higher than they would probably be normally. And after a year of Revlimid maintenance, I thought, okay, there are probably myeloma cells there. It's super likely. If they survived a year of Revlimid, then by definition, they're Revlimid resistant. And so let me add a second myeloma drug called ixazomib, Ninlaro. And so when I added that to Revlimid, I dropped the Revlimid dose a little bit and now added Ninlaro, and then went up on my Revlimid dose over time. But with the addition of Ninlaro, it's kind of interesting. My kappa-free light chains fell a little bit more. And then now, over a year ago, I decided to add a steroid called dexamethasone. Decadron is a short commercial name, 20 milligrams once a week. And adding Decadron further suppressed my kappa-free light chain. So I've been living now with these pills. So this is a pill I take once a week, 3 out of 4 weeks. This is a pill that I take every day. This is a pill that I take once a week. And I'm super fortunate that I tolerate these medicines okay, that I can access them because I have insurance that pays for them. They're extraordinarily expensive. I certainly couldn't pay for them if I didn't have insurance. And overall, I live a pretty normal life. And it's really a miracle of modern medicine that makes this possible for me. But this is not an approach that I find is widely used across most of our patients in All4Cure. But the idea of minimizing the number of myeloma cells to the absolute minimum, not confusing a test that shows no myeloma for really not having any myeloma be present, is really important. And I think prolonged maintenance therapy is going to be helpful for many patients to keep their myeloma under control, hopefully for many, many years, hopefully until really curative therapies are found. So thanks for listening to this. I'd love to hear your comments. If you'd like to enroll for All-for-Cure and you're a myeloma patient, please visit us at allforcure.com. Please like our Facebook page and post your comments. And if you like this, if you think this is useful, we have many stories that I'd like to share if this seems to be something that people like. Thank you.